Greetings. Let us learn about glue injection and its role in GI endoscopy. These are my acknowledgements. And the learning objectives today include: first, we will learn about the purpose of glue injection, and number two, we will learn about how to prepare and perform glue injection. A number of glues are available. You may have heard about crazy glue or cyanoacrylate, and one of the derivatives is N-butyl 2 cyanoacrylate. There are other cyanoacrylates, the octyl form, and the cyanoacrylates have been used all over the world for managing gastric variceal bleeding, especially fundic variceal bleeding. And this is a very labor-intensive procedure, and you will do well if you prepare for the procedure in advance. So let us look at what do you need to prepare for glue injection. You need a lot of vials of glue, and take the glue into a 3 cc syringe, 0.5 ml per syringe, and prepare at least 8 to 10 syringes of glue. I'll tell you why you need that many syringes pre-filled, because it will require multiple injections and you don't want to be caught up when there is bleeding and you don't have glue to inject to stop that bleeding. And it is 0.5 ml per syringe. Next, you take distilled water and again prepare 3 ml syringes, 3 ml of distilled water per syringe, again about 8 to 10 syringes of distilled water. And next, you need to have a couple of injection catheters available because the catheters can get clogged up. So you want to have all this material available on your back table as shown here before the injection starts. Glue can stick, and as it sticks, it can damage. And you want to prevent the damage to the scope by using a specialized oil and coating the endoscope and the endoscope channel before you start the procedure. And this is how you prevent damage to the scope and costly repairs. Next, in terms of the patient, when the procedure starts, before the injection starts, one should make sure that everyone in the room, the endoscopist, the nurse, the technician, and anyone else in the room should be fully protected by wearing the PPE, the personal protective equipment, including eye protection, if need be, wearing goggles or whatever. And that is essential. If the glue spills into any eyes, the eyes can get damaged pretty bad. So make sure you have eye protection and make sure you stop and check that everyone is fully protected. And that's the responsibility of the team leader. And once that is checked off, then you can start the procedure. Also, important to cover the face of the patient so that the patient's eyes are also protected. So, people doing the procedure and the patient eyes should be protected. Next, you want to prime your injection catheter with distilled water and learn to inject quickly. For glue injection, speed is essential. Okay. Once you prime the catheter, and as the endoscopist punctures the fundic varix, he will ask you to inject, and by that time you have your glue ready, and you inject 0.5 ml of glue quickly, and that only goes halfway into the catheter, and that should be flushed quickly by injecting 1.5 to 3 ml of distilled water again quickly. And you have additional syringes ready so that you again deposit 0.5 ml of glue quickly, followed by 1.5 to 3 ml of distilled water quickly. So you understand now why we should have all the syringes pre-filled before the procedure, because you may have to use multiple small aliquots quickly and there is no time to stop and try to prepare in the middle of the procedure. It's also important for the endoscopy assistant to say loudly, glue is going in, 0.5 ml injected, distilled water going in, 1 ml injected, 2 ml injected, 3 ml injected, distilled water done. Next, glue is ready. It's important to say that so that the endoscopists know what you are doing. That communication is critical. Next, let us look at what the endoscopist does. Where does he start the injection? Does he start at the periphery or at the center? Expert endoscopists have shown that if you start at the periphery of the varix, as it takes the bulge up, and that is where you should start your first injection, and it has been shown to cut down the risk of bleeding during glue injection. So when you inject there, the endoscopist also jiggles the needle catheter in and out so that it prevents the needle from getting stuck in the glue inside the varix. And as he is doing that, the assistant is injecting 0.5 ml of glue followed by 1.5 to 3 ml of distilled water quickly. And the endoscopist observes the change in the varix and it fills up and it shows that it's hardening. Then he may stop and go to the next point of injection. Usually it starts in the periphery and from periphery to the center. Central part of the varix is injected at the last, again using the same technique of jiggling the needle, the catheter in and out, while the endoscopy assistant is quickly injecting and communicating loudly 0.5 ml of glue gone in, 1 ml of distilled water, 1.5 ml, 2 ml, 3 ml of distilled water injected, injection complete. So next glue ready. So that rhyme should continue to go on so as to have a safe and effective glue injection. After the glue injection, the endoscopist withdraws, asks the assistant to pull the needle back, needle into the sheath, and then with the blunt end of the catheter tip, he gently palpates the varix to make sure the whole varix is solidified. And that's how you know whether you have obliterated the gastric varix. One important point that I want to share with you that the endoscopist does before posting the case for glue injection, he will look at the CT scan to see if there is a spontaneous splenorenal shunt. And if the shunt is there, what is happening is the gastric varix is draining into the splenic vein, and then from there to the renal vein, from there it goes to the inferior vena cava to the heart, and that shunt, splenorenal shunt, puts the patient at high risk for embolization as the glue is injected. So if the shunt is there, he will defer glue injection. If the shunt is not there, then it is safer to do glue injection. So we talked about a lot about glue, how to prepare multiple syringes, 0.5 ml of glue, 3 ml of distilled water syringes, multiple syringes, coating the endoscope with oil along with the channel also. Then priming the needle with distilled water, and then injecting 0.5 ml of glue and 2 to 3 ml of sterile distilled water. And the endoscopist starts from the periphery of the varix, goes to the center, and as he's doing each injection, he's jiggling and then feeling for whether he's obliterated the varix. So in summary, glue is useful for management of gastric varicose bleeding for both control as well as prevention. And there are some risks. One risk is obviously embolization. This could be minimized by injecting small amounts of glue. That's why we talk about 0.5 ml of glue per syringe so that you don't inject too much. And also making sure the anatomy does not show a large spontaneous splenorenal shunt. Starting at the periphery and not going for the center like the target cuts down the risk of bleeding during glue injection. The center part of the varix is thinner, so if you start at the periphery, you have much better safety margin. And preparing your scope with oil and preparing the channels and coating them with oil helps you prevent clogging. And most important is making sure that everybody has PPE, including eye protection. I hope this is useful. Thank you.